Sorry for the very morbid title of this presentation, but to continue our discussion of Beecham and Childress's concept of non-maleficence, now we're going to look at what they have to say about death. Since we're going to be spending a week on euthanasia later in the semester, we're just going to look pretty quickly at what Beecham and Children have to say when it comes to the distinction between killing and letting die, and then also what they have to say about requests for aid in dying. Later in the semester, we'll talk more comprehensively about this distinction, killing versus letting die, when we talk about the Rachel's reading about active versus passive euthanasia. There, we'll also look at a case where that is quite similar to the one that Beecham and Childress present about the child with Down syndrome who's born and needing a surgery, so we'll hold off on that. And since I'm holding off on that one, I'll also hold off on the case of the premature child getting disconnected from life support by the father, and instead just speak more generally about what Beecham and Childress's conclusions are about how this distinction gets used, what is implied with it, and offer up what their argument is for navigating these types of concerns. So in ordinary language, killing is associated with a causal interaction insofar as if you are killing somebody, you are responsible for that death. You have a causal connection to the outcome. And again, this is just ordinary language use. If instead you let somebody die, you are not necessarily responsible. You didn't causally intervene in a direct way to bring about that outcome. And so that's what this distinction is relying on. If letting die is permissible because there isn't this causal connection, and then killing is impermissible because there is this causal connection, Beecham and Childress are ultimately going to say that this is simplifying what's going on, and we're having a conversation about causality rather than morality. So the meanings of these terms can be quite vague too. As I was just saying, when we get to the Rachel's reading, we'll talk about a couple of cases and thought experiments where it seems like killing is equally on the same standing as letting die, and it's very difficult to discern what the difference is between them. So each case is pretty contestable. Then Beecham and Childress go on to talk about how these labels, even when they're correctly applied, do not actually determine whether or not an act is justified or not justified. What I really like about this section from Beecham and Childress is they sort of designate where the responsibility is, and it's on deriving an appropriate justification for an action. The justification is what matters, not what the label is for the action itself. So they say that rightness and wrongness depend on the merit of the justification underlying the action, not on whether it is an instance of killing or letting die. This is another situation in which we are holding ourselves more responsible for investigating what are the moral complexities of the situation, what are the justifications, can we condone this act based on those justifications. That's where the real work is done, not on making a description about that the act is whether or is killing or letting die. That's their sort of conclusion from that part there. And so they finish up by saying the validity of an authorization is what justifies or determines the morality of the action, and it's not the independent assessment of the causation. What they're saying here is that whether or not the authorization comes from that process of, let's say, informed consent, right? If you remember Beecham and Childress's framework for informed consent, we had the different divisions in which you have thresholds of competence, then you have communication of information, and then you have the authorization of a different treatment. And for Beecham and Childress, because again, respect for autonomy is one of the key principles, and it's not as though non-maleficence overrides respect for autonomy. Remember, they are prima facie principles. The idea here is that there has to be some justification for this, and that justification is derived from the authorization of a particular treatment or its refusal. Has it been through the appropriate process does it meet the criteria that we sort of hold ourselves responsible for upholding? And that is ultimately where the ethical dilemma is at, not on this question of causality. Now let's look at the idea of aid in dying, or physician-assisted suicide. As I mentioned before, we'll be spending a whole week on euthanasia, so this is a very quick flyby about what Beecham and Childress present on the topic, so to be continued. To begin, we have this question: why might physician-assisted suicide be an obligation for healthcare providers? Well, hopefully, based on what we were just talking about a moment ago, you would think that the principle of respect for autonomy is important here. Patients should have some control over what happens to them. So, especially in situations that are dire or are futile, to use our term from before, maybe patients should be allowed to exercise their autonomy to pursue or hasten their own death, to alleviate the harms or the pains that they might experience. And it seems like this is where the principle of respect for autonomy and the principle of non-maleficence come into conflict with one another, and it's about trying to negotiate that conflict for the best interests of the patients. Yep, I snuck it in there again, best interests of the patients. So what I really like about this section from Beecham and Childress is that they then pose sort of this question about, is there responsibility owed to patients purely on the basis of respect for autonomy to fulfill all requests for assistance for aid in dying? And no matter where you fall on this debate, I think that the cases that Beecham and Childress present are pretty convincing to show that this is a practice that is very difficult to navigate, and that's why we have classes like bioethics to talk about it. So on the one hand, Beecham and Childress start with these examples where, well, this one example where it seems clearly unjustified to provide assistance in suicide, which is the Kevorkian case. You might have heard about it. So this patient, Janet Adkins, received the diagnosis of Alzheimer's and became really depressed and didn't want to, lose her capacities that are usually associated with Alzheimer's. And so she sought out a way to end her life, and she ended up finding Kevorkian, who was willing to oblige Janet Adkins here in her request, and ultimately she went through with the procedure and died. And what I think makes this unjustified, as Beecham and Childress point out, is the fact that Kevorkian didn't really verify that she had Alzheimer's. He didn't do any assessments about maybe she was just psychologically in distress, because it is a difficult diagnosis to receive. And it seems like there's a sense in which we didn't uphold our responsibilities to this patient to ensure that she was making an autonomous decision that was in her own best interests. So this goes back to the respect for autonomy, not just principle of non-maleficence. It seems like autonomy is not upheld in this case. And so I think Beecham and Childress are right to say, here's a clear instance in which physician-assistant suicide is not permissible, because it seems like there was a failure to look out for the patient's best interest, do more assessments, and make sure that there is a clear discussion had with the patient before this type of procedure was enacted. However, there are also cases in which it seems pretty clearly justified to provide aid in dying, and Beecham and Childress provide this example of a leukemia patient who decided to forego this last-ditch effort to this last treatment that is usually risky, it's painful, it's not very successful, so they made the decision to not pursue that treatment. And ultimately, the doctor prescribed the patient with some, I'm going to butcher this, but barbiturates? I'm going to go with that. Something to hasten her death. And so In this case, it seems like the physician was upholding his responsibility to this patient. Why? Because this has been his patient for many years. They had built trust. He knew their family members. They had conversations with one another. They were clearly, or she was clearly competent in this situation. And it was a decision that everybody arrived at together. And so we're sure that the decision was autonomous, and it was also a case of non-maleficence because we were trying to avoid harms the best that we can. And so Beecham and Childress give us this list of conditions that seem to suggest that this is a clear case in which aid in dying is permissible. I'm just going to read them off to you, but you can find them in the text as well. So the first one is a voluntary request by a competent patient. The second one, an ongoing patient-physician relationship. Then we have mutual and informed decision-making by patient and physician, a supportive yet critical and probing environment of decision-making. So this was put up to some scrutiny, a considered rejection of alternatives, the treatment that was proposed as the only alternative. The patient ended up deciding to refuse it, given the low probability of its success and high probability of causing harms. The structured consultation with other parties in medicine, a patient's expression of a durable preference for death, unacceptable suffering by the patient, use of a means that is as painless and comfortable as possible. So Beecham and Childress point to this case as one in which it seems clearly permissible for the physician to provide this assistance in aid in dying. This is all to just say that it's a very complicated issue. That's why we're going to spend a week talking about the topic more in depth. But I do like how Beecham and Childress broach this topic insofar as we are seeing that it's the responsibility of upholding both of these principles at the same time, negotiating between them, giving our critical analysis, and ultimately trying to arrive at a resolution that is looking out for the best interests of the patient. Let's do a quick summary of what we were just covering. I know this was a pretty brief lecture, but we started off with the distinction between killing and letting die. Beecham and Childress argue that this is a pretty vague distinction. It rests on this causal description about how a person's actions are connected to an outcome. So when we talk about killing, we typically think that you are personally responsible for the outcome, which is death. And then if it's letting die, it means that, you just didn't intervene, and so now you are guilt-free. And Beecham and Childress want to say it's not that simple. It seems like there's more of a complication to this whole issue of death that is not necessarily causal. It's more so about the authorization of the decision to end one's life. And so for them, it's about following through on the procedure that is about obtaining proper authorization that is justifiable based on our moral evaluation. We were also just talking about aid in dying, and Beecham and Childress sort of make the connection between the other principle, which we've already covered, which is the principle of respect for autonomy. And we see how these two principles are in conflict with one another. That's what makes them prima facie principles rather than absolute principles. So with the physician-assisted suicide, though, it's not necessarily always justifiable. We were just looking at the Kevorkian case, but there are also cases in which it is justifiable. And we'll speak more in depth about this later in the semester. I do want to reiterate, this is something that I bring up a lot in these types of courses because it's an applied ethics course. What we're trying to do here, I'm not trying to give you the solution to physician-assisted suicide insofar as I can give you a formula to always follow and you know that you're doing the right thing. No, ultimately, the hard work is going to have to be done by you. My job here as an instructor is to provide you with a variety of tools, conceptual tools that you can have in your toolbox to be able to navigate these really messy examples. So moving forward, I just want to keep stressing to you that what we're doing in this class is trying to develop the skills to engage these very tough topics with severe consequences and prepare you to deal with them.